Pericardial disease. There is a considerable overlap in the causes of all types of pericardial disease: pericarditis, pericardial tamponade, and constrictive pericarditis. For instance, if the etiology of the pericarditis is associated with the extravasation of a great deal of fluid, then tamponade can occur. If the cause of pericarditis is chronic, then patients can develop the fibrosis and calcification of the pericardium that leads to constrictive pericarditis. Pericarditis. Pericarditis can be caused by any infection, inflammatory disorder, connective tissue disorder, trauma to the chest, or cancer of an organ anatomically near the heart. Most common infection is viral, but Staphylococcus, Streptococcus, fungi, and other agents can cause pericarditis in the same way that any infection can cause pneumonia. Most common connective tissue disorder is SLE, but regular granulomatosis, Goodpasture, rheumatoid arthritis, polyarthritis nodosa, etc. can cause pericarditis. What is the most likely diagnosis? Pericarditis is associated with sharp chest pain that changes intensity with respiration as well as position of the body. The pain is worsened by lying flat and improved by sitting up, probably from a change in the level of tension or stretch of the pericardium. EKG shows ST segment elevation in all leads, but the most specific finding is PR segment depression. Figure 3.16. Pericarditis with ST segment elevation and PR segment depression everywhere. ST segment elevation everywhere and PR depression everywhere. Treat underlying cause. For most cases, no clear cause is identified, and these idiopathic cases are presumed to be viral in etiology with Coxsackie B virus, and shares colchicine to decrease recurrences. On the exam, if an answer choice includes an NSAID plus colchicine, it is the correct answer. Pericardial tamponade. Any of the causes of pericarditis can extravasate enough fluid to cause tamponade. Compression of the chamber of the heart starts on the right side because the walls are thinner. As little as 50 ml of fluid accumulating acutely can cause tamponade. If accumulation over weeks to months, the pericardium will stretch to accommodate as much as 2 liters of fluid. Tamponade can also result from trauma with a bleed into the pericardium. It requires emergent thoracotomy. What is the most likely diagnosis? Hypertension, tachycardia, systemic neck vein, and clear lungs. Figure 3.17 Pericardial effusion. Massive pericardial effusion. A 78-year-old man with a history of lung cancer comes to the ED with several days of increasing shortness of breath. He also became lightheaded today. On physical examination, his blood pressure is 106 by 71 mmHg, pulse 112 beats per minute, and venous distension. The lungs are cleared to auscultation on inhalation. Blood pressure drops to 92 by 58 mmHg. Here are the points most appropriate to confirm diagnosis. Echocardiogram. The echocardiogram is most appropriate because the EKG often shows nothing except silent tachycardia. Chest X-ray is normal and an acute tamponade can show a globular heart. Although right heart catheterization is the most accurate to determine precise pressures, it would never be appropriate to do a catheterization to evaluate for tamponade without having done an echocardiogram first. Diagnostic test. EKG shows electrical alternance in different heights of QRS complexes between beats. Chest X-ray shows enlarged cardiac shadow expanding in both directions. Globular heart. Echocardiogram shows right atrial and ventricular diastole collapse. Right heart catheterization shows equalization of pressure and diastole. Treatment. Pericardiocentesis. Needle drainage to rapidly expand the heart. IV fluid, a hole or window placed in the pericardium for recurrent cases. Diuretic will decrease intracardiac filling pressure and may markedly worsen the collapse of the right side of the heart. Constrictive pericarditis. Any cause of pericarditis can result in sufficient calcification and fibrosis to prevent filling of the right side of the heart if it is chronic, such as tuberculosis. Clinical findings may include small sign, increase in the GD on inhalation. Normally, the neck veins should go down on inhalation. Knock is an extra hard sound in diastole from the ventricular filling. As the heart fills to its maximum, it hits the stiff, rigid pericardium with a knock. For the most likely diagnosis, signs of right heart failure such as edema, ascites, enlargement of the liver and spleen, jugular venous distension. Constrictive pericarditis is a combination of the physical findings described with calcification on chest X-ray. Diagnostic tests include chest X-ray, best initial test will show calcification and fibrosis. CT scan and MRI, most accurate test, then only after chest X-ray. The echocardiogram is indispensable for excluding right ventricular hypertrophy or cardiomyopathy as a cause. The myocardium moves normally in constrictive pericarditis. Treatment: diuretics used first to decompress the filling of the heart and relieve edema and organomegaly through removal of the pericardium. Peripheral artery disease. Peripheral artery disease (PAD) is the stenosis of peripheral arteries with the same causal factors as coronary and cardiac disease such as tobacco smoking, diabetes mellitus, hyperlipidemia, and hypertension. There is no routine screening for peripheral arterial disease since there is no mortality benefit to the obtained. What is the most likely diagnosis? The key to this question is leg pain in the calf on exertion, relieved by rest. Peripheral arterial disease pain occurs when walking up or down hills. Severe disease is associated with loss of hair follicles, sweat glands, sebaceous glands. The skin becomes smooth and shiny. Diagnostic testing: spinal stenosis pain is worse when walking down hill because of leaning back. Diagnostic testing includes ankle brachial index (ABI) based initial test. This is the ratio of BP in ankles to BP in brachial arteries. BP is normally equal or slightly greater in ankles due to gravity. If difference between them is greater than 10%, ABI less than 0.9, and disease is present. Angiogram most accurate test is not necessary unless specific revascularization will be done. Treatment is as follows: aspirin or vorapaxar. Vorapaxar is antiplatelet medication that is an alternative to aspirin and clopidogrel. Do not use when there is a history of stroke or transient ischemic attack because it can cause bleeding. Stop smoking. Kilostazol, most effective medication. Surgery to bypass stenosis if medical therapies are ineffective. Calcium blockers do not help peripheral arterial disease. Beta blockers are not contraindicated in peripheral arterial disease. Everyone in peripheral arterial disease should be on a statin. In all major vascular disease, control each of the following: PP, ACE inhibitor, LDL goal 70 mg per dl, everyone on statins, and diabetes. Heart disease in pregnancy. Which of the following is the most dangerous condition in pregnancy? B. Pericardial cardiomyopathy. The worst form of heart disease in pregnancy is pericardial cardiomyopathy with persistent ventricular dysfunction. If a woman with pericardial cardiomyopathy and persistent left ventricular dysfunction becomes pregnant again, she has a very high chance of markedly worsening her cardiac function. Pericardial cardiomyopathy. It is unknown why antibodies against the myocardium arise in some pregnant women. The ventricular dysfunction is often reversible and short-term. If the left ventricular dysfunction does not improve, then the patient must undergo cardiac transplantation. The medical therapy consists of the same drugs used for dilated cardiomyopathy of any cause, namely ACE inhibitors such as ARB, beta blockers, spironolactone, diuretics, thyroxine. Repeat pregnancy in a woman with a pericardial cardiomyopathy will provoke enormous antibody production against the myocardium. Pericardial cardiomyopathy develops after delivery in most cases. That is why ACE inhibitors, ARBs are acceptable to use. Eisenmenger Syndrome. Eisenmenger Syndrome is the development of a right-to-left shunt from pulmonary hypertension. It is seen in those with ventricular septal defects who have significant left-to-right shunting and then eventually development of pulmonary hypertension. When the pulmonary hypertension becomes very severe, then the shunt reverses and right-to-left shunting develops. Tip: pericardial cardiomyopathy is not one of the choices for the question, what is the worst cardiac disease in pregnant women? Then look for Eisenmenger as one of the choices. Pregnancy increases plasma volume by 50%. Middle stenosis will worsen in pregnancy but not emerge as pericardial cardiomyopathy or Eisenmenger syndrome.